1.
Alright, hi, thank you for coming. My name is Summer. I'm with Columbus State University, and this is my senior project, something that is very near and dear to my heart because I actually sometimes do have this as well. And my evidence-based project is how to decrease alarm fatigue. Alright, so as we all know, this is something that is an issue in healthcare that many people do suffer from. In hearing the different alarms, there's so many different technology, they all have different beeps, they all have different sounds, it's just a whole lot of noise. And what happens is this noise it affects the nurses and it affects the patients in the long run. So, just to let you know, this is the cardiac monitor, we call it telemetry. This is something we will make sure that everyone is educated on. We will make sure that everyone knows exactly what these monitors do, what sounds they make, how to fix this, how to troubleshoot it. That is number one, so that as far as everybody knows that everybody's on the same page with the telemetry. And also we want to identify patients that may or may not actually require the telemetry monitoring. This is by the American Cardiac Association. And they have standards for which either type 1, type 2, and type 3 as far as who requires cardiac monitoring. Also, all these cardiac monitors, when we're learning about them, they all have default settings. So having them programmed specifically for patients will help decrease that alarm fatigue because these are not going to alarm sometimes whenever someone's heart rate is going up like 5 beats per minute. And having the the patient's monitor set appropriately and individualized, it'll also increase the nurse response time because sometimes what does happen is there are false alarms, and these are actually more common than not. So these false alarms may actually delay a nurse to respond because it's kind of like that boy cried wolf kind of type situation. And also in having these parameters set specific to patients would also increase their overall patient outcomes. So in decreasing some of that noise and alarms throughout on the floor will also decrease the patient's anxiety. And just being in the hospital sometimes it's just stressful as it is when you've got noise coming in, you've got nurses coming in like, oh, let me check that, and it's a false alarm. That is something that, makes the patients a little bit more upset, and so it does delay their healing. So what I've proposed is a nurse-driven removal of the telemetry based on certain criteria. And doing this will also reduce nurse burnout from all those different alarms. So what is alarm fatigue? And it is just a sensory overload. This is just sounds that keep coming to the floor. It desensitizes the nurses into hearing these sounds, and you hear them, and you go in, it's nothing that's going on, and it's just a repetitive cycle. So when this happens, is that true emergencies may get overlooked, delayed, or just missed. It delays the nurse's reaction time to coming into the patient's room sometimes, and alarm fatigue is directly related to patients' overall outcomes, anxiety, HCAHPS scores, and nurses' satisfaction, and the decrease of burnout by the nurses. So what we want to do is to decrease the number of false alarms and verify that patients are actually clinically valid in having this monitoring system. Make sure everything's working functionally. Like I said, this is going to increase patient outcomes by decreasing their anxiety and letting them have time where they can actually rest and actually heal, and increase the nurses' response times. So this overall is going to increase the HCAHPS scores, which management will love, and decreases the nurse burnout, which may help with some of that turnover. So the need for this is that, 72 to 99% of alarms are unactionable. They're, hey, this lead is off. This O2 monitor is not coming in clear. So calling up here and telling us to go in there time and time and time again, it ends up delaying the overall time because you think, oh, it's just a patch or it's just a sensor, when it could actually be something more serious. But the thing is, on our floor that we actually are not monitored. The alarms are not signaling on our floor. They're in a central telemetry unit, which is not on our floor either. But what we get is the calls. We get a call from telemetry, and they'll call, and then they'll call back, and then they'll call back, and then they'll call back. So the benefit of this would be the noise level is actually going to decrease. And not just while the alarms aren't signaling on our floor, this is the sounds of those calls. Those calls coming in nonstop from telemetry. And this is something that is one of the #1 things that HCAP score surveys will have that we can directly correct, because it's asking, you know, how well were they treated? Did the nurse listen? You know, would they come in? But how loud? Is it noise? Noise is definitely one of the questions that's on the HCAP surveys that we can easily correct. So the people that, the stakeholders in this is everybody that's pretty much working in the hospital, up from the bedside nursing to upper management. So in developing a PICO question for this project, I looked at the problem was the alarm fatigue. Intervention is trying to decide whether or not it was required. And then the comparison is trying to see, it's kind of hard to say whether or not all floors actually do have the same number of telemetry units. And the outcome for all of it, though, would be to decrease the alarm fatigue, increase patient outcomes, and decrease patient anxiety, decrease the number of false alarms, and increase nurse response time. So my PICO question is, will having better policy and procedures for placing patients on telemetry help reduce alarm fatigue, therefore decreasing patient anxiety, increasing nurse response time, and overall patient outcomes? So why should a change be made? Our current policy is that telemetry calls every 5 minutes. So if you're in a patient's room and you are actually doing and giving patient care, you may not be able to get back in there in 5 minutes. These calls do escalate, and they call once, and they may talk to a tech or a CMA, and then they go up to the nurse, and then 5 minutes later, they're going to call the charge nurse. We've even called the shift coordinators. This is something that is kind of nonstop, and it's something that's kind of unavoidable, but this is listed as one of the top 10 technological hazards in nursing and in healthcare. But these false alarms do put patients at risk for whenever life-threatening arrhythmias and actionable rhythms actually do occur. So my recommendation is that all patients should be assessed and make sure that they are clinically do require this monitoring. If patients had normal sinus rhythm or 90% or greater on their O2 status for at least 48 hours with no prior cardiac arrhythmias, they probably should be, we can present this to the physician to have this telemetry monitoring discontinued. Also, patients that are non-compliant with their telemetry and take it off, don't care if it's on, don't, go off the floor, take it off, disconnect things. That's another area that they need to be considered for having their telemetry discontinued. But the patients that do require the monitoring, they need to have their settings set individually. Their current parameters on our policy is that the heart rate above 20 or 10 to 20 below, if not bradycardic. But still, that may result, and I personally had someone call me, I just want to report your patient has a heart rate of 90. Okay, that's normal sinus rhythm. It's okay. So I think that also that the revising the policy to have staff from telemetry, they need to have their staff come and make sure that this equipment is working properly, it is attached properly, the O2 probes are on. This is something that they can send somebody to correct. So this is something that would be evaluated over time. This would be maybe someone who's not directly involved in this direct patient care in this manner. We'll go and see this, you know, with a list, because telemetry does have these strips and such as that. So seeing, evaluating the actionable versus the unactionable alarms that are sent up, nurses' responses, and you know how they feel about this by a survey, and also just to see if there is an increase in the HCAP scores. So this is what we expect, because this is something that, you know, in 2013 there was actually several Sentinel events. So this is something that has been corrected, and it's in the process of continuing to be corrected. And hospitals have been required to develop and implement protocols for trying to curb the unnecessary alarms. So with nursing outcomes, the decrease in the number of false alarms, and it should also reduce the number of, you know, the relevance of nurse burnout. So, in conclusion, verifying that a patient requires continuous monitoring will reduce the number of telemetry that actually is on the floor and is required. And then also getting everything kind of specific to the patient, individualized, will help reduce those false and unactionable alarms that we have. And having a nurse-driven telemetry removal protocol will help with decreasing nurse burnout, decrease the alarm fatigue, and increase patient outcomes. Are there any questions?
Is our facility considering that nurse-driven?
There is actually a nurse that is on 6 that's working with their unit director with the same concept, that they are working on a nurse-driven telemetry protocol. Any other questions?
No, I like that.
Thank you.
Thank
All right.
you.
Well, thank y'all for coming, and I need to get back to work.
Back to work.